Ladies and gentlemen, this is episode 6 of the Healthcare Growth Cycle podcast. And today we've got on a very special guest, Ohio-based, out of Cincinnati, Neil Weiss, who's the Director of Operations and Home Care at Cincinnati Children's Hospital. And the great piece here is that Steinert Analytics is deep into a lot of the durable medical equipment space inside of healthcare. And I think it's a side of healthcare that, since healthcare is so broad, it's not as, I guess, either known about or there's not as much. It's very niche knowledge. And so bringing Neil on, I think we're going to have a great conversation to talk about growth in DME. And it's just really, really great to have you on, Neil. I really appreciate you taking the time.
Yeah, Christian, I appreciate you reaching out. I'm looking forward to chatting with you.
Yeah. So I guess if you just want to start out by giving a little bit of a background, like how did you get into durable medical equipment specifically, all the way maybe back to what you studied in undergrad, all the way to what you're doing right now?
Yeah, I'm going to tell you, I've had really a great career path. I identified early on uh, what I wanted to do. So my background's in athletic training, and it all came about because I was a really terrible athlete, and was a way to stay involved with athletics and enjoy uh, spending all that time with athletes and coaching and the X's and O's inside sport. So I went, like you said, I'm a Cincinnati bred person. Grew up on one side of Cincinnati, committed what we call the cardinal sin of Cincinnati. I moved from one side of town to the other, and people around here will understand east side versus west side. Um, I went to the University of Cincinnati and studied athletic training and there was a dual emphasis program, community health promotions with a dual emphasis, athletic training and community health promotion. So honestly, I thought I was going to be a high school athletic trainer, a high school coach, and teach. And I did my student teaching, and I met my cooperating teacher was actually a uh, starter for USA swimming and diving. So he's one of a few at the time, a few starters for Olympic qualified events. So just talking with him and found out my background. So he introduced me to the world of swimming. So I got to do some U.S. swimming trials as a student, and then as after I graduated and took my certification, my licensure, exposed me to some various levels of Olympic sports. I worked with some really competitive baseball teams. They're amateur baseball teams, but they, known nationally. We produced, you know, 50 plus major leaguers, 2 Hall of Famers. It's great experience. I've taken my athletic training career and I've worked with pro rodeo. So really covered a gamut between pro sports, recreational sports, high school sports. But I worked for, background. I was in a hospital. I was an athletic trainer in outpatient physical therapy. We transitioned from one
Okay.
hospital organization to another. So I spent my first 29 years in my career inside hospital organizations, and then was offered an opportunity. We were doing a workforce reduction. So I was offered essentially an early retirement. So I jumped on that for a minute, and I realized I'm not a person that's very good at staying at home and
Sure.
doing a whole lot of nothing. So was fortunate. I found a local company. They're spread throughout Ohio, West Virginia, parts of Indiana, um, Louisville, Kentucky. It was a home respiratory, home medical equipment company. So inside the hospital system, take a step back. Inside the hospital system, my primary role within orthopedics, we kind of morphed into doing our own in-house DME program. So we had bracing
Okay.
orthotics primarily, so all soft goods, orthopedic soft goods. Um, and I worked from just a
I
staff
actually have a
person.
question there.
Yeah, go ahead.
Yeah, excuse me. So in terms of an in-house DME program, at what point does a hospital system go to like a supplier or a distributor versus deciding that they want to do in-house durable medical equipment? Like, where is that? Like, what's the justification for one or the other? I'm just curious.
Yeah, so it all just comes down to what they're willing to invest in, because you can have, say, like a stock and bill program where you have, a vendor partner that's going to come in and make sure everything is stocked, and then you fill out the paperwork from the clinician standpoint. Physician orders it, gets all the paperwork together. Then they come in once a week, collect the paperwork, send it out, bill it, do all that follow up work. Or we just kind of do it in house. So if we're going to do it, if we're going to have the product in here, we should be collecting the revenue for it. So, and it requires having some staffing on hand. And it requires having people that understand the compliance aspect, what it takes to
Gotcha.
get the 855S and get a DME number, and following through all the compliance and making sure you're ready if Medicare came in to do an audit, or you know any of those
I
um,
see.
type things. So it just depends on what they're willing to jump in on, and their
Okay.
commitment level to doing that. So then, as I
Yeah. Makes sense.
as I left the one organization, I went to that home respiratory company, and that um, it just really opened my eyes to a couple of different things. One, uh, there's so much more involved in what I call true DME, versus just the bracing orthotic component, which was my sort of my specialty. That was my niche. And then you get into and you find out all this other stuff. It's like, oh, this is really robust and very diverse. And but the second thing I realized is, even though that company was great, they treated me very well, I really enjoyed it. I'm a creature of the hospital system. And there's something,
Okay.
people that are outside hospital systems that come and work for them sometimes struggle. And sometimes those of us that are brought up through the hospital system, we get out of it. We find out that our comfort level is back in the bigger organizations. So that led me to, the open role I have here, and I've been here since April of 2024, almost 2 years.
Wow. Yeah. So on the leadership side of things, and I want to focus on this with you because when we first talked initially, I got this great energy from you, and being you kind of talking about being someone who's going to figure things out. I see why you are in the position that you're in, and I'd like to dig on that a little bit more. What is some critical aspects of leading a successful home home health operation at a hospital system?
So what I pride myself on is, I don't want, and I actually said this in my interview when I came here, is I don't always want to be the smartest person in the room. And if I am, we're in trouble. I want to surround myself with really good people. So my medical director, my senior director, both very strong leaders, very good visionary type people. I have a respiratory manager. She's been doing this for such a long time. And I joke around. I'm like, I remind her, I'm like, you've forgotten more about what it takes to do respiratory stuff than I'll ever know. I have, my manager of our intake team. He's got a background in health informatics, and it's just a knowledge base of people. You know, from my agency director and um, our private duty nursing director, both very sharp people. The leadership here was just very good. Our pharmacy director, been here for a long time, knows what he's doing. So I'm part of a team that we work well together. We play off each other's strengths. But to build that team, I always felt like I have to trust my people, but I have to be visible. I have to be present. I have to um, not just be the person that comes and says, "This is what we're doing." It's, well, let's take a look at this. How's this going to affect? How's my decision up here going to affect people downstream? And how do other departments? How do their decisions affect my team? So it's always a matter of just honest and open communication, and just driving things forward. I always like to say, my first question to my teams are, do we take care of the patient? We'll figure
Mm,
everything else out, but let's take care of the
yeah.
patient, because that's why we're in healthcare. That's why we're here. It's why we're doing this. So let's get this together and get the patient taken care of. Now, if I have to write something off because they're out of network and we have to write it off, well, that's fine. Let's find somebody let's partner with somebody and get them what they need, and then we just go pick our equipment up. So there's always,
Sure.
those type things. So let's keep why we're here relevant.
Yeah, and another question there, do you guys keep your own equipment on site, or do you go through suppliers, or is it a mixture of both? I'm just curious, again.
So the three areas that I have direct oversight of within home care, I have our complex rehab department. So that is all of our adaptive equipment. That is, power wheelchairs and power assisted wheelchairs, standing devices, walking gait trainers, specialty strollers, car seats, things of that nature, specialty beds. I have our home respiratory department, and then we have our home medical equipment department. So the home medical equipment department support like pharmacy, we support respiratory, we support our agency nurses, we support our private duty, nurses and nurses that are at home. So I always say pharmacy may have the drugs, I have the equipment, and then the nursing teams are the way that we administer everything. So we all have to work hand in hand. So yes, to answer your question, sort of off the roundabout is
All
both.
of it.
So
Yeah,
I have a supply room. I have, a couple thousand pieces of equipment for, in stock. And then maybe I think our pharmacy probably has 3 or 4 thousand kids on service. And a lot of those will have some sort of administering device, some sort of pump, some sort of, so we have a lot of products here. And then like my complex rehab department, those are all patient specific. We don't have like a storeroom where you can just come in and shop and pick. It's made for that child. It's made for that patient. That they're measured for it, and things are special ordered and shipped in and built specifically
sure.
for that patient.
Yeah. Wow. So how does the DME or the home care department fit into the overall growth of a large hospital system? Like, do you have certain sales numbers that you guys have to hit um, to deliver and fulfill different orders? Like, how does that all work?
So we partner with multiple departments. So my main partners, so for rehab, my main or yeah, custom rehab, my main partners are our OTPT, leadership partners. So they see the patients, physicians are sending them to OTPT, and then those OTPTs are meeting with my team, and they're getting the adaptive equipment together. Um, we partner with pulmonology, we partner with cardiology, we partner with gastroenterology and motility and all these other clinics to provide their uh, whatever a child needs. So whether it be a G tube or ostomy bags or catheters. So there's a lot of departments that we have relationships with. We have relationships with, um, certain floors of the hospital where we see most of our kids come out, and we have like care managers that work on those floors and they help coordinate everything. We have nursing teams like uh, the home agent, like the agency and
Yep.
private duty nursing liaisons and coordinators. They may get the order and then they'll send it over to our team. And, we have a whole rev cycle and off team that we work with that, they get
Okay.
the benefits and they get all of the authorizations. And then we, place the orders, ship them. We have a delivery service that if they're within a certain radius, we'll deliver it to them. Otherwise, we, utilize FedEx, UPS, Cardinal, and we'll ship things to patients' homes.
Sure. Yeah. And is that rev cycle team separate from the other, like the overall hospital system? Just because I know that DME revenue cycle can have very specific
Yeah.
um, rules and
So,
quirks. I know it's a very niche expertise, so that's why I ask.
yeah, so the team that I work with is exclusive to working with, home care and a couple other smaller departments, where they focus only on us. They answer up through the larger organization, but I work with the same, 6 or 7 people. I work with the director and a couple managers, and then my team works with, you know the supervisors and the managers as well. But to let I try to let my people do what they do best, and I try to stay out of their way. So they have those relationships and they, you know, regular, but I'm in like daily communication with some of them. I mean, some of them are just regular emails that, hey, we're converting things to purchase. Here's our Monday report. Here's our Friday report. Here's what everything that's ready to convert. Here's what needs to be
Yeah.
converted. Here's what's closing out. So I monitor a lot of spreadsheets and a lot of access databases and um, where then I have my people that when I go to them, I'm like, just tell me where we are with this. I work closely with our finance team, that
Sure.
they report through and outside of home care, but there's actually a director of home care finance. And he's a
Yeah.
couple offices away from me. His team sits just outside my office. So I work with one of them a little bit more closely because she takes care of all our product conversions. So when it converts to purchase, she's on that end of it. So it's a
Wow.
lot, like I said, it's a lot of moving parts at times.
Yeah, absolutely, and super fast paced. Um, what what are some hurdles that the DME industry faces in 2026 and beyond? Like, what are you kind of seeing in your experience where there might be some bottlenecks? I kind of want to do a little bit of an exercise where are there certain hurdles where tracking, X metrics would help to kind of get over those issues? So where are you kind of seeing some
Yeah.
bottlenecks?
So
Maybe just generally in industry.
my biggest bottlenecks that I tend to run into are no different than anywhere else that I ever was. And it just all comes down to um, like missing documentation or missing signature, or if something's prescribed for a certain length of time and it's not filled out correctly. So instead of, you know, you may be on a CPAP and you're going to use it indefinitely. So instead of putting, length of time, 99 months, they leave it blank. So you can't get the off. So you know, that slows down our off teams process. And then if
Okay.
there's incomplete orders, that happens a fair amount, or they, you're going to get a van order or whatnot, and it's an incomplete order, or you run into a lot of uh, miscellaneous coding when you start bundling up some of these wheelchairs. And because it's a miscellaneous code, they want to know what we're going to bill it for. And then you have to go do a price research, and then they they'll give you a yes or a no. And then we run into the same with uh, that I saw like surgeons would run into with, is this procedure necessary? You have to do a face-to-face, you know, review,
Wow.
peer-to-peer. And so we have like our OTPT, sometimes we'll have to do a peer-to-peer. We have to get, a certain physician may have seen a patient, and that may have been like maybe a resident came through, and then they put the order in, but now we got to find somebody to sign off on the order, do a new order, or a face-to-face visit, a face-to-face encounter may have expired because by the time the patient was, see, I can only handle patients once they become outpatient. So we'll have
Okay.
patients sometimes that'll be ready to go home and they get readmitted, and that backs up my process. So then I have to sit there. Now the face-to-face expired. So I have to go get new notes, or they were doing well and it's just an annual update and the physician won't sign off because they haven't seen the patient in a year. So then you have to coordinate those visits. So
Sure. Yeah.
it's the same in almost every aspect. I mean, we just run into those same types of procedural things because, when you get insurance and CMS and all of our, you know, organizations that kind of
Yeah.
limit what they're doing. There's so many steps. You want to make sure that you're sending things out cleanly, quickly the first time. So it's a lot
Right.
of work on our front end, so the back end's quicker.
Sure. Yeah. What about resupply? Like, is that ever a bottleneck or um I'm just kind
Yeah,
of curious about like yeah, go for it.
at times, we've had issue with that. We run into learning curves with patients. So a mom or a dad, maybe there's X amount of catheters that are approved for a month, but mom and dad are the ones, using catheters the first month. The patient's been on it, and they mess up and they're running short because they had to use too many catheters in the first half of the month before they got used to putting it in. So that we run into that where we're trying to get more out the door for them. And so that the patient has what they need. It goes back to what I always say, we take care of the patient. Does the patient have what they need? Or do we, hold off and then not get it? Greater Cincinnati is where most of the country had that a pretty nasty snowstorm come through last week. So there was, supply chain disruption between us getting what we need and then coordinating care with like FedEx and UPS because they have to ship things and their planes and trucks are grounded until they can get things cleared out. So being proactive and looking and saying, hey, mom and dad, you've got an order that's going to be coming up due next week, but there's shipping delays. We anticipate shipping
Hmm.
delays. Can we get these out sooner? Can we work? And that sometimes we run into the problem where we ship it out sooner. It's not covered. Pharmacy sees that a lot because you can only give out medications at at a certain cadence. And if it goes
Okay.
before that, it's not covered. It's and we all know pharmacy prices can be pretty high. So you want to make sure that you're following billing rules. You want to make sure you're following, common sense rules, but you also want to make sure that you're trying to give the patient everything that they need in a timely manner.
Yeah. So to the timely manner part, if you had to choose like maybe two or three metrics, I know you mentioned spreadsheets and access databases. Are there any particular KPIs that come to mind when you're thinking about like just leading the overall health of the home care department?
Yeah. So on a financial side, we look at, I get a daily report from our finance team that shows, where we are in my three departments. So I know financially where we are, and I can look to see what maybe why is something lagging in one area versus another. You look at, specifically like custom rehab. Maybe they're because I incur so much of that cost up front to build a wheelchair to buy a standard, then I, I paid for it, but they're not going to be fit because patient schedules or PTOT schedules, and we need to have the patient on site. And the mom and dad run into a problem with bringing the child to their PT visit, so I incur a lot of costs up front. So I can look at that, but then I can look at schedules and I kind of forecast what I've got coming up. So I'm always looking at, I use like the cost of goods sold as my variable there, looking to make sure that I'm not getting too high on my cost of goods sold versus my where I'm billing and getting reimbursed. But the home medical equipment is much quicker because if we're using our local delivery service or if we're using a FedEx or a UPS, I'm getting real time confirmations. So patient may call today, say I need X. We can fill it today because upstairs, right above me, we have a supply room. So our supply chain partners are upstairs. They could fill the order if they're within a certain radius. I can have it delivered with, you know, same day or next day in theory. Or if they're outside of our normal radius, I can drop it FedEx and they're going to get it within 2 days and I get real time
True.
confirmations. So then I can
Okay.
confirm things a little bit faster and I'll see that revenue a little bit quicker. So
Interesting.
I'm always like a little bit behind in rehab. My respiratory service line is based a lot on rentals. So a lot of our stuff is month to month rentals. So I see that.
Got it.
I want to see steady growth throughout the month, but I know at the end of the month it's going to really ramp up because then all of a sudden everything got confirmed for that month's rental, and then the next month it's going
Yeah.
to be three and a half weeks of slow growth. Where the HME team
Yeah.
sees it rapid growth. Is that team is incredible. Four very hardworking young women that just get things done. I mean they're troopers. I mean, they just as soon as things come in, they're getting them confirmed, getting them off the desk, and making sure that those orders are filled. And I mean, you'll never walk over there and not find them on the phone with the patient, and they're just always motoring through. Just they just, fantastic
Yeah.
crew. I mean, they just get it done.
And so let's dig into that a little bit. So do they actually help the patients learn how to use the equipment pieces, or like what's kind of their role when they're talking to a patient?
So they can. We have some vendors that do bring in products and do education with them every right now and then, and so that it more or less helps them understand when mom and dad call in and say we've got this product. They're familiar with it, and they can help walk them through a little bit of that. But we're fortunate that our nursing staff tends to be available for a lot of this, and physicians, the referring physician clinics, and they've done a lot of that front end education and are available uh, for that education should the parent have an issue. And let's just come into the office, we'll show you how to do it again. So it's, we all work hand in hand, but yes, they are available to answer some very basic questions. They keep in mind that they're non-nursing, so that they can answer what they can answer, and they can answer what they feel comfortable, and they'll tell the parents, "I'm not comfortable answering this, but we'll pass it on to our nursing team, and somebody will reach back out to you." And or if it's something that has to go back to the clinic, we'll reach out to the clinic and let them reach
Yeah.
back out to you.
Wow. So moving on, from more like the operational pieces and the health of the home care department, metrics you're looking at. Um, One of the things that is such a common topic right now is value-based care. And I was just curious from a pediatric standpoint, is value-based care part of pediatric hospital systems, or is that not common?
Is it common? Yes, it is common. I look at it as, the thing that I have the um, most experience within that is like our remote patient monitoring. So we have a team within here that
Okay.
does all the RPM, and currently looking at ways that maybe we can expand that and look at. So when I had said before, my medical director, she's incredible, very forward thinking. And we just had a meeting earlier today where we brought this up, and she's talking about how can we do more, because we've been piloting a small program with a select few patients, and it's gone extremely well, and it's been very successful, gotten a lot of praise from the parents that were involved with it. So now it's like, what are other opportunities we can do with that, and how can we maybe spread it across to respiratory? How can we spread it across to other parts? So this is really, really early in its infancy on how to do that. But you look at, you know, not not the same, but very similar with the value bases. My complex wheelchairs will have a ton of bundled charges. So you get paid
Okay.
X amount of dollars, but by getting paid this larger number, you're not going to hit us with all these different miscellaneous charges. But I can't build this wheelchair without these smaller pieces. I have to have a chest restraint system. I have to have leg rests. I have to have, but some of those may just be
Sure.
included in the general cost of this one component to the wheelchair. So there's some
Okay.
bundling that goes on inside of that. My respiratory, there's things that we bundle up in the rental charge, where we don't, nickel and dime patients for certain things. It's just part of it. You can't have a concentrator and then not have tubing to connect to your nose, or to your, if you're, you know, a vented patient, you need to have that. So it's like there are certain pieces that you can bill for, certain pieces that people can purchase outright, and then there's just some components that just get included in just cost of doing business.
Sure. Okay. Yeah, no, I think that'll be really interesting to the listeners. So we're at about the 30-minute mark, and just the topic with I know it's kind of cliche, but AI in healthcare in 2026. Have you seen any changes in the DME industry with AI in the mix now, and how are you using or not using AI, and your reasoning behind that?
So I I have a couple of varying thoughts on AI.
I'd love to hear
Was
them.
I was late to the game in trusting AI. It kind of, I'll be honest, it freaked me out. Uh, there were some just fiction novels I read and things of that nature, and AI was just that creature that just was out there, and I don't understand it, and it scared me. And then I started, my son being of college age, um, showed me how he uses it. He's like, I use it like Google. He's like, Microsoft Copilot, I just use it like Google. Instead of just looking something up, I just type it in there. So then I started looking at it from a vantage point, how can I utilize this? And being part of a large organization, we're very cautious, about protecting patients' private health information. So we don't put a whole lot out there on that. Um, but I started using it about, let's educate myself on some of these items that I don't know a whole lot about. And let's look at HCPCS codes, and are we using the best HCPCS code for this? What's the reimbursement? What are we seeing for reimbursement from other states? And are we, what are competitive bid prices, and getting into some of that. So then that was kind of interesting. What I would like to see it, I would like to see some sort of predictive denial, much like an HR company might use applicant tracking software. Can we put our can we put our order through this, and can it kick out in real time? You're missing this, you're missing this. This is not going to be approved by this insurance because, we looked at all of Anthem's plans and they don't cover this. Or
Yeah,
there are these exclusions
yeah,
that you can look at, and then use that from an education standpoint and say, if we know this isn't going to be covered, is there a way that we can still provide this for our patient at a decreased cost? Is there a way that we can
sure,
provide this? Can we go back and help educate clinics about, product A may be available, but product B is covered, and let you make that decision. I'm not the provider. I don't get into that. Let's let you be that person that says, this is what I need for my patient. And then I'll work to see, I'll work with all the teams about getting it in here to offer to the patients. But I would like to see something to that nature. I getting with the, like, in the complex rehab department. I would really like to see where some of this AI is going to go to make these adaptive equipment more adaptive,
yeah.
more dynamic. Seeing how, I mean, there's nothing greater than seeing the smile on these kids' face when they got independence. I mean, it
Awesome.
warms you through and through. I I get really emotional thinking about it. It is the coolest
Wow,
thing in the world, and to see how maybe
that's
AI
amazing.
is going to help them, and help them
Yeah.
have a life. I mean, help them, have freedom, go out and play and do things like that. I'm excited to see where that's going to go.
Thanks for sharing that, Neil. Yeah, I think too, it's always good to, like you said throughout this whole podcast, think about the patient first, because I often think about like healthcare from a data analytics perspective, and the opportunity every day to walk into clients and try to help them use data to better serve their patients for a better patient outcome is really like the main goal of why we're doing this and why we're working in healthcare. So I think that's beautiful. Um, And I think that the idea on predicting denials is a very, very interesting uh, use of AI in DME revenue cycle. I've even thought about how can we help, either a hospital system or a DME company, predict a certain order to maximize the claim on their side, right? So they
Yes.
can get a better reimbursement payout, right? I mean, just to think, that may be a selfish way to look at it, but I've been playing around. It's similar thoughts. So to hear you say that, it's a really, really good point on predicting denials. I think there'd be a huge value
I mean,
for that.
I
So thanks
think
for
there's a
sharing that.
lot of uses for parents. I mean, you can look at it from, a patient satisfaction standpoint. You can, utilize plug-in metrics to see what we can do maybe to better the patient experience. what else can we do? Can we use it to call patients to remind them that it's time to reorder your supplies so that they're not
Sure.
waiting for the last minute? They can plug in
Reminders.
your insurance will allow you to order on this date. We'll remind you on that date so that it's a valid order. We don't have to say, well, you're too early. So I think there's a lot of great uses for it. I think
Yeah.
we need to be cautious about, in a healthcare system, you need to be cautious about how you use it and, make sure you're using it responsibly and not leaving patients information available to be hacked out.
Yep. And that's, yeah, because I think about that every day. Like, you know, the uptick in data breaches with AI in the next 5 years. Are we going to see that in HIPAA and PHI data? And it's definitely very concerning. Um, yeah. All right. Well, this has been an awesome episode. And I really again appreciate you coming on. I appreciate you sharing the impact that your work is having on these patients at Cincinnati Children's Hospital. So, ladies and gentlemen, this is episode 6 of the Healthcare Growth Cycle podcast, and we can't wait to see you on the next one. Thanks so much for joining us.
Thank you.